person tonight. Thank you for coming along, Lahiru, who we met at the ABC's boot camp, ABC's of Anaesthesia boot camp, those who attended on the Saturday. And I was quite inspired by that, so I approached him and said, hey, could he join us tonight and do a topic that was asked for? So this was a topic that was raised as something that they wanted to hear about. And it is a core topic for GPAs, particularly for transporting patients or patients in the emergency department. But also, you know, we do ventilation settings in theatre and so forth. So Lahiru, please, a bit of a quick introduction for yourself too, if you don't mind.
Yeah, absolutely. First of all, can everyone hear me all right? Yeah, so a bit about myself. I'm a full-time anaesthetist at Western Health in Victoria. I just do a lot of teaching. I think a lot of us get into that space because it's just a lot of fun and helps us keep sharp and keep honest with what we know. Today we're going to talk about the ABCs of mechanical ventilation, just practical tips and tricks. And I hope you'll see how pretty straightforward it can be after you follow a few principles. Obvious disclaimer with this stuff is that general information about medical conditions of treatments. Everything is, nothing is specific about patient care, and obviously, consult your treating team and your supervisor about that. So I'll base this on the Datex Omeda GE ventilators, and we'll go through the Oxylog 3000 as well. But all ventilators, they're just, pretty much the same. They've all got the same principles. So, I hope at the end of this, you've got the principles that even if we stick you with a Dragon machine or some other machine from wherever part of the world has different machines, you'll still be able to use the same principles and it won't be so bad. So, and always remember, a fancy, complicated, expensive ventilator is really just a glorified bag mask. And I'm sure a lot of you have heard this before, but this black box of a thing, this really expensive piece of equipment can be completely taken away and all you need is that Liddell bag. Good. Look, basic assumption I always go through, everyone here, I believe, is intelligent, capable, cares about doing their best and wants to improve. So, you might say an amazing thing at one stage and say something you wish you'd said better. Doesn't matter at all. I don't care. No one cares. We're just here to learn. So please feel absolutely open in asking any questions, challenging me on anything. I'll tell you now, I am not the expert of ventilators. I just know what I use, practically speaking. I'm definitely not the expert of the Oxylog, which we'll go through as well. So, if anyone has any extra useful tips, please share with all of us, and that will be absolutely fine as well. So, what we're going to cover, firstly, the aims of mechanical ventilation. How does this go very bad? What can I do to stop this going bad? And how do I choose the settings? And we'll also go through what to do if the ventilator is exploding or malfunctioning, and some basic examples and tricky lung examples. So what is the aim of mechanical ventilation?
You want to deliver oxygen and to remove carbon dioxide.
Perfect. That is absolutely the main stuff. I've just checked. So definitely do oxygen, definitely remove CO2. Brendan, which one's more important out of those two?
Oxygenation.
Absolutely. And sometimes you might, especially in, when you're out in the country, or if you're especially going into the ED setting as well, some people are just fatigued. So you sometimes want to rest the respiratory muscles as well. And the other aim is just not to damage the lungs. So easy, right? How do you know you're oxygenating?
Usually having some monitoring is handy, particularly your SATS probe. And while you're at it, I guess Untitled CO2 as well. So you're getting the CO2 as well.
Fantastic. If you didn't have any of those monitors, you're in transport and things are bumping everywhere and nothing's working.
If nothing's working, you're looking at the patient to see whether they're cyanotic or pink and perfused.
Sometimes when I've been in a transport vehicle and I'm particularly paranoid, I'll also just look for that chest rise and fall. I'll put my hand on the patient's belly just to make sure I've got that. When there's so many sensory inputs around you, and I try to offload one of those to a different part of my body. So hand on the stomach often helps me in those times where I've just got so much cognitive overload, clogging of the ET obviously, and breath sounds and auscultation if you're really, really worried. But I love the fact that we've got SATS and Entitled almost always, and that just helps everything go really well. The next question is a bit of an interesting one. I want everyone to have a think about this. How do the lungs get damaged when we're using a ventilator?
I was just going to say, well, overextension of the lungs initially.
And that overextension, it's got a word. What do you reckon what is happening to that overextension?
I guess it's pushing the alveoli beyond the size they want to be at maximum.
Yeah, and that's called barotrauma. It's great you said that, because that's the number one evidence-based way you damage lungs badly in the sickest lungs, like the ARDS lungs. Good barotrauma. What else?
I guess you can push air into spaces it shouldn't be, so that tissue's around, but that's not, I guess, directly trauma to the lungs themselves.
I call it barotrauma. You can do bad things with pressure and air going into the wrong spaces. Barotrauma. Those are actually the two most relevant ones for us. So oxygen toxicity can be interesting, but I'd almost go to say this is almost irrelevant in the anesthesia setting. It's just not something I think about or worry about. I'm sure it's something that you worry about in hyperbaric medicine and maybe ICU settings when you may need lots of FiO2 100% for many, many hours, but not in anesthesia. But definitely barotrauma could be a thing. Barotrauma absolutely could be a thing. And there's another thing called atellect trauma. There's also biotrauma and shear strain, but again, a lot of this stuff, it's very hard to go too wrong in anesthesia because it's a short time frame. What is this and what can I do? So just to go through oxygen toxicity, it's just pulmonary oxygen toxicity results from longer exposure to increased oxygen levels at normal pressure. You can have prolonged exposure above normal oxygen partial pressures or short exposures to very high partial pressures. And these cause things like oxidative damage. Again, not the biggest thing to worry about in anesthetics. And again, as of this talk, not the biggest thing, but who knows what we're going to find out in the future. Now, barotrauma, it is something that there's more research about. So lung injury caused by alveolar overdistension. So they did this landmark trial that showed that 6 mils per kilo decreased mortality in the ARDS patients significantly compared to 12 mils per kilo. So roughly, this is the aim now, 6 to 8 mils per kilo. And they use predicted body weight. We're not going to go too much into that, but let's say ideal body weight, 6 to 8 mils per kilo. And that's what you should probably aim at. And a lot of times the machine's default isn't 6 to 8 mils per kilo. So just to be mindful that that's probably where we should go. Does it make a massive difference in short cases? Probably not. But why not do for healthy lungs what we do for the sickest lungs? How about barotrauma? This is lung injury caused by high transpulmonary pressures. It may even occur at lower airway pressures if you do something where there's a relative change in pressure, like negative pressure pulmonary edema. Think of that patient, the young patient who's got laryngospasm as they're coming out of the anesthetic. Maybe you've taken the LMA out a little bit too early, or you're transferring them and they're a bit too light, and then they take a massive forceful inspiratory effort. You'll hopefully never do that again, because then your patient might be in a HDU for a night and you'll be pretty stressed out. Always aim at a pressure in these healthy lungs of less than 20 centimeters of water. So those are my variables really. Less than 20 per pressure, 6 to 8 mils per volume. Atellect trauma, again, I don't think about too much. It's really hard to know if you're causing this, but it's a form of lung injury where you get repeated opening and closing of your alveoli. So you really just don't want that. So, super small lung volumes can cause this, as well as having the wrong type of PEEP. But we can go through that later as well about, how to set optimal PEEP. Again, barotrauma, shear strain, not for this talk, more for kind of ICU level stuff.
Lahira, if I can interrupt. Oh, look, question just in time. Hey, trying to stay below pressures of 20 in anesthesia, especially with pneumoperitoneum or obese patients, I would find that a bit of a struggle. Is that an ideal world thing, or?
Yeah, it's an ideal world thing, and like most things, we end up having a rule, and we have to break that and make compromises depending. So we'll go through some scenarios where we'll have, require high pressures, and then how do we make do with that? You can always follow a principle of the lowest pressure necessary to achieve your aims. And one of the crucial things would be, how much can I compromise on things with pressure? We'll definitely go through that. Okay, let's set the ventilator. Simple, there's only a few things to choose, which is great. And if things go wrong, it's pretty easy to fix. So select the FiO2 first. So what do you choose for pre-oxygenation?
So 100% oxygen on 6 litres is a typical sort of answer. Some of them more than that, 8 and 10 litres a minute.
Absolutely. I'm a big fan of just putting a lot of oxygen in. So, 100% flow, 6 litres per minute, good seal and time, this is what you need. So why do you want that?
We want to pre-oxygenate patients because we want to do denitrogenation. So
Yep.
meaning like increase the oxygenation or oxygen level prior intubation to increase or the sleep apnea time.
Excellent. We'll go through it. Let's say your FRC is 30 mils per kilo. So that's about 2 liters, 2,000 mils for just a standard 70 kilogram person. 80% of the 2,000 mils is roughly, let's say 1,600 mils. How many mils per minute oxygen a standard person would use? This is one of those common things that your bosses might ask you, so I thought I'd just quickly go through it.
3.5 mils per kilo, so roughly 250 mils for the average person.
Fantastic. So let's say you have 1,500, 1,600 mils of reserve. How long before that reserve runs out?
6 minutes-ish.
Yeah, absolutely. If we're just rounding off, that's perfect. So this is my maths, and that's roughly what you get. And these are ideal circumstances. Anaesthetized patients might have less FRC, they might have a high metabolic rate, you might have diffusion out of that system. So, you might get 5 minutes at best, and maybe even less in sick patients. So just a good number to think about, and that's why we pre-oxygenate, and something you may be asked. So hopefully you'll be able to smash that answer now. Now, how about if I want super fast and better pre-oxygenation? So I thought I'd just run through. So there's some circumstances where I actually might do this because I've actually never done this on myself. Has anyone ever tried PSVPro pre-oxygenation? So what you do, sometimes you just want to, you've got a patient who's quite obese and you want to get the pre-oxygenation as good as possible because maybe they're a difficult airway. Most of the time we are accepting of an end-tidal oxygen of above 80%. So I thought I'd just quickly go through this with you. This is my method for rapid pre-oxygenation. I turn it to 100% oxygen, 15 liters per minute, and then I go to PSVPro mode. This is a pressure support mode, which we'll go through later. And then I select that and confirm, and I put, say, the pressure support on 5, and then I just start breathing. So I'm going to try and do this. When I do this with really sick patients, I can get to their end tidal above 90% really quite quickly. And I find that that's an amazingly good advantage for that. So I just wanted to share that with you. Now, the other thing I wanted to share is sometimes your patients are mask phobic. They're the original anti-maskers. And one of those tips is just to use this straight away. So you don't need the mask pre-oxygenate. You just cover someone's nose, tell them to breathe through their mouth, and just ask them to breathe normally through that. And if anyone hasn't tried that yet, it's just a really easy way of doing that.
That's a great suggestion. So for someone who's claustrophobic.
Yeah, it's so easy to do. And, there's just, they're never, I've had so many people, maybe once every 6 months to a year, someone's claustrophobic and you just go, not a problem. Here's a licorice stick, or you just, put whatever part of that tubing into the patient's mouth, make sure that they're not breathing through their nose, and you can just block it off. Pre-oxygenation is so vital. It's easy enough to do. So what do you do? Patients are mask phobic. Pretty much just easy. Use the licorice connector instead. Now, what do you want for extubation? It's pretty much the same thing, right? I do the same 100% and increase flows. Some people choose 90% to prevent atelectasis, but this is really an evidence-free zone, and does it really matter? So, for all the same reasons as pre-oxygenation and intubation, I just turn up the flows, 15 liters, wash out my gas, and it gets the oxygen levels really high as well. So what do you use for maintenance in a normal anaesthetized patient? This is where you might have some discrepancy in what people do.
I use an FiO2 of whatever I can safely wean them down to once we're in flight, and usually it's somewhere about 40 to 50%. And for sick people with a higher metabolic rate with minimum flows, I try and run it a bit richer, somewhere between 60 and 80% sometimes.
Yeah, good. And it's good that in your circumstance, you really need to judge other factors. And, normal elective patient, you can sometimes just go down to 21% and it probably doesn't matter, but you need a bit of room to move. So that's exactly the point that I wanted to make, that there's not too much evidence. So 30 to 80% is what most people would do from what I've seen in normal practice for normal lungs. There's no real evidence of benefit or decrease surgical site infections. And there was a recent meta-analysis that showed that in the anesthesia settings, anywhere, 30 versus 80%, no change. I avoid very low FiO2 just in case of airway loss. And when you think about it, if you're just starting out in anesthesia, the complications for airway loss are horrendous. You just don't have the experience to rapidly solve that problem, or the confidence or necessarily the skills. So I would avoid that in all cases. And then I avoid very high FiO2 to avoid causing lung injury and masking progressive lung injury, which we'll go through in our cases as well. Selecting flows, this is pretty easy as well. When you select high flows, it's kind of obvious. You just want a rapid change in the gas you're delivering. So if I want a lot of oxygen to go in, like in pre-oxygenation or extubation, I just turn up my liters to above 6 liters. When you want a rapid change in nitrous, say you're gassing a kid down and you just want a lot of nitrous in there, that's what you do. You change the flows to high. Pre-oxygenation, also sudden hypoxemia. If you've got a patient who's suddenly desatting to 60, sometimes I'll see my trainees just dialing up 100% oxygen, but the flows are still 1 liter. So you really haven't given the patient the end-tidal alveolar concentration of 100%. So you really need to turn the flows up as well. Also washing out volatile. And when you select low flows, obviously these are less than 2 liters a minute. That's just for maintenance. And most people would choose anywhere from really low flows like 0.5 liters per minute to 2 liters per minute. And that's what I see most people doing. Okay, so this is where it gets interesting. And this is where, when you're in your practice, this is what could be most confusing. I'm going to try and make this as simple as possible to kind of break down the fact that a lot of the names here are almost needlessly complicated sounding. So what modes do you know already? There's volume control and pressure control. There's your synchronized intermittent mandatory ventilation, and the same SIMV, but with pressure control instead of the mandatory ventilation being volume control. Then you got the PSVPro, which is pretty much just the pressure support part of the SIMV. And finally, the fancy mode, pressure control ventilation volume guarantee, which tries to do the best of all worlds. So let's go through why this is so simple to me. So with the volume control mode, you pretty much just decide on volume or pressure. Firstly, you just dial a value, 500 mils, or a pressure, 10 centimeters water. You select a respiratory rate, 12 is pretty standard. And then you select PEEP. Most people would choose somewhere 5 centimeters water of PEEP. And that's it. And if you haven't done anesthetics yet, this is about the simplest formula you'll get, and that's what you'll almost ventilate everybody on when you first start out. So with the fancy modes, it's only actually adding one extra thing mostly. So these fancy modes of SIMV or SIMV-PC is just volume control or pressure control, where you dial a volume or dial a pressure. But then what happens if the patient tries to breathe? So maybe the patient isn't paralyzed, maybe you're in ICU and you want to wean them off the ventilator. If they try to trigger a breath, the machine will be able to sense that the patient's breathing and then give them some support. So what that looks like then, you choose all the usual stuff, the volume or the pressure, choose the rest rate, and then choose the PEEP, and also choose how much pressure support you want to give. And often that's anywhere from 5, 10, maybe 15 centimeters of water. So PSVPro gives pressure support to patient-initiated breaths. So imagine PSVPro is kind of like the CPAP mode, but with an extra bolus of pressure support. So if if the patient is breathing but needs a bit of help, maybe you're weaning them off a ventilator, maybe it's the end of the case, or maybe you've got an LMA in and you just want to give the patient a bit more support to increase the volumes. Every time they trigger, there's a flow sensor, and the machine then just delivers a bit of support for that. So if there are no patient-initiated breaths, it then reverts back to some backup mode. And this is often SIMV pressure control or any other backup mode. Finally, pressure control volume guarantee just delivers a pressure control breath to a preset volume. And so it gives the lowest pressure to achieve a set volume, and also gives pressure support to patient-initiated breath. So imagine this, I want to give pressure control ventilation, so I get a very even pressure profile, but I don't ever want to go above a volume, and that's what I'd use this mode. So it gives the lowest pressure to achieve a set volume. And also, anytime a patient might initiate a breath, it also gives pressure support for that.
Could I just ask, with that last mode, I've always thought it sounds a bit grandiose, because I think, if I'm not wrong, that the volume control, can you also have a pressure alarm anyway, like this? Do you know what I mean? And so it's like you've already got the alarm, so you kind of got the best of both worlds already. What's the real difference in practice?
Yeah, so that's good. Your pressure alarm is almost always set at 40 in an adult ventilator. So most times you'll never get to that, but maybe you'll just want the lowest pressure for any given volume. Let's go into this volume control mode. So imagine I'm setting up a case, FI is there, I'll generally go to something like 50, 40, 50, 60%. I'll put my flows down to 2 liters, turn my SIMV on, and for any standard person, let's say they're 70 kilos, 6 mil, 6 times 70, anywhere from 400 to 500 is roughly appropriate at a rest rate of 12 and 5 at peak. And that's all pretty standard. If I went to a pressure control mode, instead of setting a volume, I set a pressure. And again, I often just start at around 10 because you can still get some pretty decent volumes with 10 at pressure in very good lungs, young lungs, healthy lungs. These fancy modes, let's say SIMV, PSV, the only real change there is now I've got this pressure support dial instead of where I had the peak dial. And so anytime, so now you can see I've just got a normal patient being ventilated. If my fingers are the diaphragm here, and I try to trigger a breath there, you'll see that there's a little blue trace there. And that's the machine sensing the flow and then giving pressure. If you've ever ventilated someone with a Liddell bag and they start taking breath, it's kind of like having your hands on the patient, on that bag and seeing that they take a breath, and then you support their breath. So it's kind of like what you do normally when you're ventilating someone with a Liddell bag, and you're just, applying a bit of support to them. So that's your PSV, so SIMV PSV mode. SIMV-PC is pretty much the same as the previous one. Again, you just set a pressure control. So again, a bunch of fancy names, but really you're just altering only a few different variables while we do this. PSV is essentially just the pressure support part, as I mentioned. So even though there's numbers here, that's just the settings for the backup mode. So if the patient doesn't breathe at all, like in this scenario where I'm not providing any trigger, it's going to back up to SIMV-PC, where I'll have a pressure of 10 and a respiratory rate of 12, and that's where it'll back up to. And you'll see that in probably about 30 seconds.
Which mode is this one?
This is PSVPro, and it'll always back up to SIMV-PC or something like that. And so as you can see, hopefully from that screen now, it's now backed up to the backup mode. So you'll never stay too long with an apneic patient without doing the safe thing, which is ventilating. I'll switch it back to PSV and just show you what that looks like now on screen. So I've got PSV, I'm just squeezing the bag, and then you're seeing that the ventilator is going up. You're seeing a few blue squiggles there, and that's just showing that these are patient-initiated breaths. And if I do it really regularly, again, the machine triggers and just keeps ventilating. Quick summary, we need to deliver oxygen and remove CO2. It's very logical, right? We avoid oxygen toxicity, but really it's volume, barotrauma, that's the big stuff, and epileptrauma I've added there as well for completeness. When programming the ventilator, we're just choosing FI, flow, the mode, respiratory rate and peak, and for those fancy modes, pressure support as well. There's not too much to it, and you can't go too far wrong. Just have a play, try the different modes when you're in theatre, and see what they do for the patient. But let's get practical. Let's go through some cases. I'll add a bit of complexity as we go on, and I'll offer some opinions as well. Again, so take these with a grain of salt. Okay, set your ventilator. I want you guys to take this example, and I just want you to write down some numbers, and then we're going to discuss what we're going to do. So 50-year-old, 80 kilos for lap collie, fit and well, and they're intubated, and there's just a maintenance period. Just tell me what your numbers are. This is just an example of, if you've never done anesthetics before, that's what a normal setting would look like for most people. So, if you were to do that, you'd be completely safe. Some people use pressure control. It doesn't matter too much. Let's look for the standard, and then you can change depending on what your supervisor says or depending on what you learn about the patient. Good. So for everyone, this is what I've done. I've used 40%, 1 to 2 liters per minute, volume control ventilation mode. 500 is that's 6 times 80, 12 respiratory rate, 5 of PEEP, and there's no pressure support needed.
And I suppose what's important about lap collies and that is you're varying between steeply head down or flat, you're varying between a pneumoperitoneum and not. So by selecting a pressure support, you're selecting a volume control, so the pressure will vary widely during the case.
Yeah, the pressure will vary, but at least you'll definitely deliver the volume and you won't suddenly get no volume. These days, I gotta say, I'd probably just run pressure control ventilation volume guaranteed. So I've always got roughly the right volume at the lowest pressure, but we'll go through that in a second as well. So take a point, my default setting is volume control ventilation because this targets the best evidence for morbidity in the sickest lung. And in most lungs, this will never ever cause barotrauma. So again, very safe when you're starting out. Pressure control ventilation, even at 10, will occasionally deliver greater than 10 mils per kilo. So, if there's no advantage to one or the other, I just target the volume with the volume control mode. Does it matter in most short anesthesia cases for delivering large volumes? Probably not. But again, I'm doing for healthy lungs what I do in the sickest lungs. Why not? Okay, let's try this case. Another basic example, right? 40-year-old male, 70 kilos for an open inguinal hernia repair. It's an LMA case, and it's the start of the case, so the patient isn't really breathing up. So it's the start of the case, and you kind of want them to breathe up, but you also want to make sure you're delivering anesthetic as well. For FI, anywhere 40-50% expense, fine. I like that you said, you might need, again, there's no right or wrong. You might have high levels of sevoflurane, so you just run 1 to 2 liters, or you might want to run higher flows, but you want to get that end-tidal volatile to the right level before they start the first incision. Think about this in another case where it might be a perianal abscess or an anal fistula or something where it's so stimulating that you want the patient really, really deep at the start. So you wouldn't do that thing where you just have the patient, not breathing and just ready to spont ventilator. For example, many of us would do this case. We wouldn't click him onto the ventilator at all. We'd just have them on the bag, and then once the patient, once the surgeon incises, the patient definitely starts breathing. Personally, I use a pressure control mode for that, something like SIMV-PC. So I might just have 10 centimeters of water pressure. The esophageal sphincter pressure is 15. So I always try to make sure it doesn't go above that, just so I don't cause insufflation of the stomach. So that's why I use the pressure control mode. That said, plenty of people are using volume control mode, and that's fine because the pressures are never that high in healthy patients. I target a low rest rate because I do want them to breathe. So I want the CO2 to climb, but I still want to deliver the volatility. So that's why I've got the rest rate of 4. Again, in a long enough case, these are just small details. Whether you run 4 or 12, it just means you'll end up having the patient breathing slightly later. Not a big deal. PEEP, because they're going to spont vent soon, I don't put any PEEP on. That's fine. And in the SIMV-PC mode, I've then put a pressure support of 10. As soon as they start triggering breaths, I'll get them ventilated to give them breaths. How about this one? A 4-year-old, a 20-kilo child for a supracondylar fracture with an uncuffed endotracheal tube. Take 30 seconds. Think about what the modes you would use in an uncuffed tube in this young 4-year-old. The reason I use pressure control there is if there's a leak in the circuit, the volume is lost, but the machine doesn't know the volume is lost. So it will tell you it's still at 500 mils, but the patient's lungs have only received 200 mils. Whereas with pressure, the pressure received is the truth. So I will know exactly how much pressure was in that to that lung, and as the patient exhales, it'll be received. But that's right. So leak circuits, pressure control, it guarantees you'll get the right amount of ventilation there. So yeah, 40%, I've just put 40% again, 50 to 60 is fine. Flows 2, pressure control mode, 10 to 15 of pressure depending. I put the respirator at 12, but I actually, what I do for these cases is they end up breathing. So that's why I don't really get too much about the respiratory rate. And as soon as they start breathing, I might switch to a PSVPro mode. But you're absolutely right to put that respirator up. and that was completely valid. 5 pretty standard. So that's good. So take home point number 2, for leaky circuits, I use pressure control ventilation. So using volume control gives uncertain volumes into the lung. If pressure is the limiting variable, therefore you can target this as well. So, in those instances where I'm worried that high pressures could insufflate the stomach, like an LMA, I target the pressure control setting. Let's take this example, 7-year-old 90 kilos intubated for total hip replacement. You want the patient to start spont venting at the end of the case. So, you're getting to the end of the case, you want them to start spont venting. Think about what modes you might do to help you facilitate that. So again, I'd run something similar. The reason you gave is exactly right. So as I go to the end of the case, I might actually turn up FI to 80% or something similar. Flows keep them the same, but yeah, SIMV-PSV mode. And then, so you just did slightly the opposite way that I would do it, but again, completely fine. So SIMV-PSV means that I will give these 500 ml volume mandatory breaths at a rate of 5. And then as the CO2 climbs and the muscle relaxant wears off, then the patient might start breathing and they get a pressure support of 10 in this case. If I did it the other way, which is completely valid, which way was giving PSVPro, because maybe you'd seen some blips on the end tidal and you went, I might be able to get this patient breathing. But then if you're wrong, you just go into the backup mode, like the SIMV-PC mode, and then you just wean them off slowly and maybe unparalyze them. So completely fine. So there's really good ways you could use these modes just to make it a really easy anesthetic. In ICU and other circumstances, you probably want this mode to assist with ventilator synchrony. So the patient who's just been on the ventilator for a while, you don't want them constantly paralyzed because you don't want to get some kind of critical care myopathy. So you really want them to just be tube tolerant and you're not fighting the ventilator. So you'd really try to fine tune these modes to help with that. So use SIMV modes to get spont venting in the patient. Low respiratory increases your CO2, and when the patient starts breathing, the pressure support ventilation will support any extra breaths that the patient takes. So you can switch to the PSVPro or just the manual bag and then continue the patient's spont venting. So sometimes as soon as I see that the patient's breathing by themselves with minimal pressure support, I might just flip the ventilator to the bag and the patient just continues as they were. Many operations often just need paralysis for the tube to go in. So for example, if the patient's an emergency, there's an aspiration risk, needs a tube for any other reason, but not for surgery, they might not need paralysis for the rest of the case. So I'm not really fussed if the patient breathes. I'll just turn the PSVPro on and maybe even reverse the patient. Think about that, a lap collie, you put a tube down and you paralyze the patient for surgical exposure. But then other cases that might be like a ankle ORIF or a hip replacement where you might put a tube down for reflux or aspiration risk. As soon as the patient starts to breathe, that can be completely fine. You don't need them paralyzed for the rest of the surgery. Okay, this is kind of something we mentioned briefly before. You've got a 70-year-old male, 120 kilos, let's say, the laparoscopic radical prostate in the steep head down position. And now the pressure alarms are just going off. Think about it for 30 seconds. What are the settings you'd use? How would you, balance the conflicting priorities of this patient in steep head down and everything that's doing to the pressures, but also making sure that you have your aims? What would you do with your settings?
This is a bit of a tricky one. I'm not entirely sure. I'm assuming the surgeon's not going to be happy with us asking to be less head down.
Hey, that's a really good point. There's a time when you will have to say, look, this is messed up. We're going to have to just take away the head down for a period of time or decrease it or do something. So that's a really good point. But before we get there, what can we do?
I'm also assuming they've got a tube in.
Yes.
So I guess if we need to oxygenate with less pressure because the pressure alarm's going off, then we need to up our oxygen and up our flow. So FiO2 up to 80 or so, flows up a bit more to 6. I guess. But just with that,
the problem that you'll get with the pressures will be not FI or flow problems. So you can actually, for now, as long as there's no hypoxemia, you can keep the FiO2 exactly how it is and the flow exactly how it is. but you may change the mode. So yeah, keep going.
Okay, so I'm not sure. So if it's alarming because the pressure is incorrect, I guess we have to adjust the pressure. Provide more pressure support for the patient or add some PEEP, maybe both.
Yeah, that's good. So, if it's your pressures that are alarming, let's say you're in a volume control mode, that means that you've got that spiked pressure profile. So that means if you have a spiked pressure profile, you're not doing the maximum pressure for over a period of time. So you're really right to say, I'd use a pressure control mode. So you might have started with a volume control mode, but I'd change to a pressure control mode to maybe somewhere below the pressure alarms. Like say, I'd start with 20, maybe go to 30, knowing that I've really just got to ventilate this patient. But I'm trying to stop the alarms happening. Let's say the alarms are happening, regardless, you may then have to increase your rest rate as well to try and get your CO2 to come down. And this is one of those this is like a more advanced case, obviously. Not only do you have a steep head down position for these laparoscopic radical prostates, but the patient's really heavy, and your CO2 is just going to be climbing. And mostly I'd say that CO2 climbing to big numbers isn't the biggest deal, but you get cerebral vasodilation, you could get cerebral edema, especially in long cases. And so you really want to try and get that CO2 down in some of these cases. So you might do everything from pressure controlled, as well as increasing the rest rate, maybe even taking it off PEEP, just to make sure that you're getting as much volume in and out as possible for the pressure that you're giving. But that was good. So you're addressing the point. The problem is pressure, therefore I address pressure as my variable.
And Lahira, a couple of people have made some comments, including Shulk, who didn't have a microphone. But looking for other things, traps here, they were mentioning like other than just pneumoperitoneum and head down, maybe there's a problem with the circuit or a blockage in the tube, even blowing a pneumothorax. They're all possibilities. So going back to the patient and checking, yeah.
Absolutely. And sorry, only because I'm making this very much ventilator-centric, but Liz is absolutely right. You go through your whole, what I teach is the phases of problem solving and crisis management. Definitely go through all of those. And then when it comes, if all of those are normal and it's just a mechanics problem, then this is kind of the system of using a ventilator to problem solve this. But absolutely right. You don't want to miss out on any of those really important things. So yeah, if it's pressure that could cause a problem, use pressure control ventilation. So when might you need to target a pressure to avoid problems? And every now and again, I can just imagine that when if you're a GP anaesthetist working in some of the rural settings that some of my mates who are GP anaesthetists work in, they get some of the scariest cases that you'll ever see. So severe obstructive lung disease, severe restrictive lung disease, maybe COPD with bullous lung disease, and one lung ventilation. These are all some really tricky cases where pressure is your limiting variable, and you will need to use pressure control in this situation. Oxylog, because again, this is the ventilator that seems to be everywhere. This was my favorite ventilator. I remember when I was training, we used to either take the big ventilators that were the ICU ventilators, or fortunately we could disconnect and just get one of these ones here. So I'm just gonna show you this one now. So first of all, it's compact, it's easy to use. It sits on the ICU beds and the transport trolleys really easily. And I find that just the fact that it's space saving is amazing. So I'm definitely not an Oxylog expert, but the same principles we just learned in those extra sections, we just apply here. So I might just unshare my screen. Actually, first of all, Life in the Fast Lane, great website. It's got this little page called Own the Oxylog, and it just kind of talks about each of these settings. And I might just quickly mention that, there's only a few variables that you can have with this ventilator. So first of all, I might just go through it on this picture. Can you see my arrow? Greg, if you could wave if you can see my arrow.
Yeah, all good.
Perfect. So with this ventilator here, as soon as you turn it on, it immediately goes into a very safe mode, such as this SIMV mode here, which I'll show you in a second. And when I first saw this ventilator, I kind of looked at it and panicked a little bit. But then I went, you know what? I know what I'm doing. First of all, I'm checking that the patient is ventilating, the chest is rising and falling. And then I'm just going to make sure once the patient is safe, then I'm going to figure out this ventilator. And all it is, dialing and, moving through these various options. So the first one here, as everyone can see, what volume do I dial it to? And I can just, it's already preset here to 500. What's the respiratory rate? I just choose something reasonable. And then this one, they've chosen 10, 12, 14, 16. So again, not something that's crazy. That's a very reasonable number to choose, but I could choose 12 just for standard. The pressure max is the next one. So this is a real important safety dial. I'd often have this set at 40 just for standard sake. But then you can imagine in some of your sickest lungs, you may have to turn that up. And I'll talk about that in a second. The FiO2, again, if you're in transport situations, you probably want a bit of room to move. You probably want to have a situation where you have a bit of a buffer. So I would probably err on the side of higher oxygen levels, especially if they're just generally going to be hypoxemic for whatever reason. That's really all I ever use in these ventilators. And that might surprise you. This is quite a complex looking device, but if I could tell you one thing, there's just one mode you really need, which is the one here, SIMV. You alter these variables, and then all the rest will sort itself out.
I might just add for some of us that we're not lucky enough to have an advanced Oxylog like that, so you won't even have an ability to titrate the oxygen.
Oh, so it's just 100% straight up?
Yeah, 100%.
So the first thing I do, so the interesting with this is I do need an oxygen supply. So I've got a cylinder over there. Most cylinders, like this CD cylinder they've got here, is roughly about 450 to 500 liters capacity when it's full. So that's important to know. At normal settings, so say 500 mils times 12, I'm using around 6 liters per minute of oxygen. So when you do the math, what we roughly say is judge the time taken for your transport, calculate the oxygen in liters, and then multiply it by 2. That's how much oxygen you need to take. So say this is using, let's just go 10 liters per minute, and say you've got 400 liters. So you've got 40 minutes. If your transport is 40 minutes, take double that. That's roughly the calculation that I've used. So what I'm going to do, I'm just going to start. So this one doesn't need a power supply. It's got the battery supply, but it definitely needs to have an oxygen cylinder connected. The newer models of, I think, other ventilators have their own generator, so they don't need to be plugged to an oxygen source, but this one does. So just turning it on like that. Makes a few sounds. And again, the best way to learn this stuff, just find one of these somewhere in your ICU or your SIM department or your transport unit or ED and just play around with it. Just chuck a bag on the end like I've done here and just play around with it. So this knob here is a selecting dial plus if you press it, you can, confirms things. I'm hoping I can do all of this together. So the first mode it comes into is SIMV with pressure support. That's the one we said was, just really good for, if the patient initiates breaths as well as just giving mandatory breaths. So it's a very safe mode. For most of your transports, I would suggest that your patients are going to be paralyzed. You have far less problems with paralyzed patients than unparalyzed patients. I would routinely just go into that mode, knowing that I'm probably not going to need the pressure support anyway, because I'd rather my patient doesn't even try to breathe especially if I'm a junior anesthetist and I'm in a tricky environment that's unfamiliar. I don't want to be thinking about what the patient could be doing and having dyssynchrony with this ventilator. So that's the first setting, which I'm just going to leave it at that. If you wanted to change settings, you just have to press that and hold it down. It starts flashing and then it changes. If I take it off too soon, it doesn't select that. So as you can see, I had to press it for quite a few seconds and then it changed. So I'll go back to SIMV pressure support. Now, let's just go through these things. So there's 500 mils there. Yeah, simply with that dial, I can turn it up and down. And you can see that this now causes a pressure alarm because I've taken it to 1,000 mils. So I'm just going to go back to 500, 490 rather. The frequency, again, 12 is pretty normal, but I can go up to, rapid ventilation like that, as you can see. Probably here as well. Let's go back to 12. Imagine I've got an asthmatic patient and I just need to avoid the pressure limits and alarms. I can turn the pressures up with this dial here. Going to put that to 40. Finally, the oxygen FI, I can change doing this dial. But again, let's say a lot of the times that you're going to be using this transport monitor are the sickest patients. There's no shame in having this patient on 100% the whole time. The extra little button you might want to press in an emergency if you're running them on low FI is a 100% oxygen button. So if I press that, it lights up and immediately tries to get the FI straight away to 100. I'm just going to turn that off now. Inspiratory hold here is just the interesting thing. You won't really have to use it. It's not too difficult to play. Like, it's not dangerous for you to play around with this. You just press that and it holds it at the volume that you previously set. Again, just have a play around. You can't really go too wrong if your volumes are normal with that. This button's always useful because these things always alarm. The silence button is often the first thing you learn to press in an anesthetic machine. A couple of extra settings. So if I want to vary the settings, there's 5 pages here of settings. The ones that are important are the fact that I might want to vary my peak. So if everyone can see that there, I use the settings dial to toggle through the pages. And the most important one there is probably PEEP. Because in some of your sickest lungs, you're going to need 10 of PEEP or something. So select and move up to 10 or 15 or whatever is appropriate.
Lahira, does
Yes.
it allow us to alter IE ratio because we might have to transport asthmatics?
Yeah, good. We're going to go through an asthmatic section, but I will try to find that. The reason why I'm not too fussed about that, IE ratios are a thing people talk about, obviously really important. You need a long expiratory time. If I have an asthmatic, this might sound controversial, I care less about the IE ratio. I just want a long expiratory time. So I just put really low resp rates because then your E fraction is going to be huge. So an IE ratio of 1 to 4 at 12 breaths per minute is still going to be not as much E time as if you had 4 breaths per minute.
That was a really good point, everyone. What you said then, low respiratory rate and very simple to set up.
The final thing I want to show you then is this values was really useful. Right now I've got them on 80% oxygen. I can toggle through the values just to make sure that I'm actually delivering volumes if I'm ever in any doubt. So I've got an FI there of 79%, which is about right. 7.6 liters per minute is my minute ventilation. I keep toggling through there. I've got a PEEP, pressure mean, minute ventilation, 1.7 liters per minute, and then the frequency, and then the volume title. And I can just always check those values if I'm uncertain. That's really it, guys. So that's how I think of this ventilator. I think of like every single other ventilator. I can put a bag on there, and actually, this is probably a good lesson. If I ever, let's say you're going to work in a lot of different settings, it's going to be really annoying for you in terms of unfamiliarity in some of the harshest environments and with the trickiest patients. So what I would do in those situations is, use these principles of just going through each of the dials, knowing there's only a few variables, but just chucking a bag on it to make sure that it's working is just such a useful little simple thing to do when you're unfamiliar with the ventilator. Play around with it and then transfer the patient onto it. So let's get some practical FiO2 tips. So no one really knows what the correct FiO2 is. Let's make sure the SATs are fine, the FiO2 is adequate, and your patient isn't dying of hypoxemia. That's probably the right answer to that. But also, I think that maybe we can use a logical approach to guide practice. So let's take this situation, 50-year-old for shoulder replacement with a difficult airway. The patient was a difficult bag mask and a grade 3 intubation with a bougie and good positioning. An LMA not used. So if you've just started out with anesthetic, that means that this was not something that was fun for anyone. And I'm going to, let's say this was a difficult intubation and, I definitely want you to have extra help the next time. What FiO2 do you choose for this case? Remember, we were choosing lots of FIs over the last few cases. What would you choose actively? Give me a number. The fact that you said 50, that's pretty standard. A lot of people would run it on that. You have a lot of time if something goes wrong. So this is a case that has limited access to the airway just because of the drapes and everything. But also if the ET was dislodged, depending on who I was, my experience, what the airway was like, I might need more time to reintubate. I might need more support. So I might choose a higher FiO2 to buy time if this happened. So maybe somewhere along 60 to 80%, depending on, again, experience, assistance, equipment, and all the other things that come into put your performance and those performance factors. So when you think about that, so, I'm not really targeting FiO2 because of the patient. I'm targeting FiO2 because of the patient and all the other situations. And I can think of other situations where this might be similar. Any difficult airway case, any difficult access case, prone position surgery, shared airway, ENT type surgery. There's always every few years some kind of report about a prone position tube that was taped on, the saliva or sweat gets into that tape and the tube just falls out because it's been a 12, 14, 24-hour case or whatever it is. Now think about this one, 80-year-old, 70 kilos for emergency laparotomy due to a bowel obstruction, has COPD and is concerned, and you're concerned that the patient, because they've been in bed rest, in hospital, while they're diagnosing this problem, they're probably developing a lung infection as well due to this prolonged illness. What FiO2 do you choose and why? You're right to say, you just want something that's safe, right? You want something where the PaO2 is, 100 millimeters or above, and, you're not causing hypoxemia. They're obviously pretty unwell. So maybe somewhere like 40%, I've said. So the reason I say somewhere lower is that if she had worsening hypoxemia, this would become apparent immediately at a lower FiO2. So imagine that situation that the lungs were brewing something, maybe they've aspirated, maybe they've got a pneumonia, and now because the patient's intubated, sputum plugging and inflammation and all the rest of it, splinting of the diaphragm from all that pain previously has caused more of a problem. Once I realize that the patient is becoming hypoxemic during this long, bad operation, I could increase my FiO2 from 40 to 100, and that suddenly buys me a lot of time whilst I'm diagnosing and treating the issue. Imagine the converse of that situation. If I already had a high FiO2, maybe I was running FI of 80, and I didn't need the FI of 80, the lungs would have to deteriorate a long way before the SAT started to drop. Now at 80%, the SATs start to drop, and I can only go from 80 to 100. I don't have as much time to sort out my problem or prevent any further problems from happening, depending on what that is. So just another way of thinking about FiO2, think of what your risk is and where you want that risk to be. So this take-home point number 5, I might choose the FiO2 based on safe oxygenation and the situational risk. So risky airway equals high FiO2 to give you time to regain the airway, and risky lungs equals lower FiO2 to detect worsening lung disease. Again, as long as the patient has a safe PaO2 to start with, or safe saturations to start with.
It might actually be a good segue where you're then trying to diagnose lung issue.
Yes.
Greg posted, could you kindly comment about recruitment breaths or using a SI option?
Yeah, absolutely. So recruitment is one of those things where you're trying to expand the lungs that have become atelectatic or squashed. If you think of your 5 causes of hypoxemia is caused by FiO2 problems, hypoventilation. These are all very easily treatable. I turn up my oxygen, I ventilate more to bring the CO2 down. Then I've got VQ mismatch. So I've got diffusion abnormality. That's often pre-existing lung disease. So you want their baseline state optimized. And then your final 2 problems can be VQ mismatch and shunt. Shunt's probably the most treatable and the most common cause of acute deterioration or hypoxemia in a patient who's anesthetized. So when you're trying to figure out all the different reasons why a patient might have shunt, and you're trying to slowly go through that process of diagnosing and treating, one of them is going to be atelectasis or sputum plugging. And the way I might want to expand those lungs that have been clogged up is to do increasing PEEP or recruitment maneuver. There's a few ways you can do this. So essentially, I'm just going to give you 2 ways to do this. The Alfred did a study a few years ago where they had someone on, say, 16 centimeters water pressure control ventilation. So forgive me if I don't get this exactly right, but it's roughly 5 centimeters water of PEEP for 5 breaths, then turn it up to 10 for 5 breaths, then 15 for 5 breaths, and then finally 20 for 5 breaths. And that way your maximum pressure is 36, which is still safe, and you've done a very stepwise and testable and epidemiologically testable method of giving a recruitment maneuver. The other way is if you don't want to do that, you literally just dial your pressure to 40 and then just hold the patient inspiration with the bag, making sure your pressures don't go above 40. You would be very careful with this. You wouldn't want to do this in a patient with bad, risk of a pneumothorax, like say bullous emphysematous lung disease or something like that. The other ways, sometimes you've got these fancy modes on your monitors. You can press a button that says vital capacity breath, and that on some of these electric monitors just gives you a vital capacity breath for a period of time, and that acts as a recruitment maneuver. But again, the end point is the same. I'm trying to expand the lungs of atelectasis. So any previously collapsed lungs I expand. It's just with increased pressure, held for a period of time. It's pretty cool to see what happens. If you ever want to check what happens, besides the SATs increasing, you can just turn on spirometry. So often there's a button called spirometry, and it shows a little graph. Sometimes you can see this little number here, compliance, so you can't see the number, but just trust me that there's a number called compliance when you press spirometry, and you can see how the lungs have changed just based on the recruitment maneuver. So what I love about all this is, a lot of anesthesia is real time. You do something, it changes. I change ventilator settings, the lungs actually change. So it's really cool to see, if you have a play with all the different monitor settings, you can see so much to do with what you've done, actively in any moment. Think of any case at all. You're in a new hospital, your supervisor's having a break and didn't give you their mobile number. Everything is unfamiliar. The ventilator starts alarming. There's no rising flow of the chest and no end-tidal CO2 trace. What can you do immediately to solve this problem in just one step? Anyone, shout out. What would you do to solve this problem in one step? Go to the bag. Excellent. So a few people have said go to the bag, which is great. I'm giving you so much, I guess, detailed knowledge, lots of case examples, lots of examples. But I want to keep everything in perspective that if this machine or that machine goes wrong, maybe you're in an unfamiliar theater, maybe you're on transport with the Oxylog, it just doesn't matter. Worst case scenario, I've always got the Liddell bag or the self-inflating bag with me, and none of that's a problem. I can always make sure the patient's safe with that. So this is what I want. So taking point 6, self-inflating bag is a solution to most ventilator malfunctions. Okay, so I thought we'd end with one of the trickiest cases you'll ever get, but definitely one that you could get. 25-year-old presents with asthma to emergency. No allergies, they're a smoker, but they're sat to 79% on 15 liters via the Hudson mask reservoir bag. Fatiguing, unable to speak, loud wheeze that's now quiet. They're treated with everything, so repeated salbutamol nebs, ipratropium bromide or atrovent nebs, and magnesium. Nothing's really working. What are your thoughts?
Imminent respiratory collapse, got a silent chest, he needs to be intubated.
Absolutely, this is bad news. So you call the emergency and help intubate, you do an amazing, successful intubation. How do you set the ventilator? So I want everyone to think about their settings right now.
Initially, I'd be wanting to have a decent FiO2. So it's just an emergency. This person gets 100% oxygen until I've set aside myself that we are oxygenating optimally.
Perfect.
They're going to get a total volume of between 6 to 8 mils a kilo if I can achieve it. That'll be my target volume. And an appropriate flow rate, it's maximal at the moment, and it's going to be maintained there at least until we start to see oxygenation improvement, because we're not introducing volatile. We may well as a maintenance pattern later, but in the ED setting, no.
Actually, let's for exercise sake, let's say you're in theatre now, and let's say you do introduce volatile, and you run a bit of high volatile because it is a bronchodilator. So you just use two liters of flow because that's all you need really. Which mode were you going to use, volume or pressure?
For this person, I'd probably be looking at pressure because that's going to be the greatest resistance, but I want a minimum volume.
That's really good. So pressure is a problem, so you choose pressure control ventilation. And I've said there's plenty of people using volume control ventilation as well. Not the biggest deal, but let's talk about the worst case scenario. At an even pressure, you get the most volume for the pressure that you can be limited to. So I agree with that. What pressure would you dial it up to?
Look, I'd be accepting pressures up to 30 as average, or setting my alarm at
Yeah, absolutely.
It depends what the initial pressures are actually showing. So I would actually test this with my bag and the APL initially.
Yep.
And then I'd probably give myself 10 or 15 centimetres above the APL wherever I can safely limit it at. But I guess the simplest answer is the lowest safe pressure to achieve the required pressure and volume.
I did exactly the same. So I'd stepwise go up to 20, 30, even 40. And in this worst case scenario where you have a seriously tight chest, you may not be able to get 50 mils, 100 mils even at 40. But just know that you go to the lowest pressure required to achieve some volume to get your oxygen in. So what kind of respirator do you want to use?
I'm going to aim for a low respirate because I still want them to exhale as completely as I can achieve.
All right, give me a number.
So somewhere between 6 and 10.
Beautiful. Now, you do 6 and 10, and let's say the patient starts, their blood pressure, which was stable, now starts to fall. What do you think is happening, and what do you do?
So that's starting to suggest that we're actually causing filling issues through increased intrathoracic pressure, which is a dynamic hyperinflation problem.
Perfect. That's exactly right. Gas trapping dynamic hyperinflation. How do you solve this problem? This is heading towards death. So what do you want to do?
I want to unstack them. Yeah. So open the circuit, let them exhale.
Perfect. And just get what that means to everyone. Like, you've got this patient who has poor oxygenation, you have trouble ventilating, and now they've gas trapped, so their lungs are just filling with oxygen and they're not exhaling it because they're so obstructed that venous return isn't happening, and the patient then is about to rest. So very counterintuitively, disconnecting the circuit and giving time, letting that air flow out is the only thing you can do at this point. And have you guys heard of the Lazarus effect, the Lazarus syndrome?
Mm-hmm.
Yeah, so it's where a patient died, was pronounced dead as they were walking away after their aggressive resuscitation attempt. The patient's blood pressure came back, the sats came back, he was alive. They came back to try and resuscitate again. Again, the patient died. And they did this, what I've heard, 2 times before they realized, well, we've got to stop over-ventilating this patient. So that is the solution. Just leave them alone to allow that exhalation to occur. Really counterintuitive, but worst case scenario with asthma, this is where you go. So that's really good, Lloyd. So now that you've sorted out the blood pressure comes back, gas trapping is resolved for the time being, what do you turn your settings to now? Same or different? Yeah, good. So Brennan said reduce respiratory rate, permissive hypercapnia. Exactly. So, if you dial down to 4 in this kind of fake exam kind of setting, I say then, well, CO2 climbs to 100. What do you do? And just know that permissive hypercapnia is a thing. That's what you need to do. You need to accept the fact that this patient just cannot have a high respirate to get rid of their CO2, and they've got very low volumes as well, that you would rather have the CO2 climbing than the gas trapping occurring. So that's the really massive conflict that you will face in these patients. I've only had a couple of these patients in that time, but I do know that there's one, in my training, I've had a few patients who have incredibly sick lungs, who we've done lung transplants for, and they were literally not ventilatable, and they have unrecordable CO2s. So it's a very bad situation. The CO2 climbs, but we maintain oxygenation, and we wear the fact that we cannot control the CO2, and that's the far lesser of those evils that we're balancing up. The tidal volume targets for this are completely different. So you're not worried about 6 to 8 mils per kilo. This is that kind of emergency situation that you'd be lucky to get 50 to 100 mils in a severely bronchospastic asthmatic. So don't even worry about the elective tidal volume aims or the ARDS tidal volume aims, because this will be different to that. Good question. So I'll just go through that. This is roughly my plan, which we've gone through. And just at the bottom there, I've got the fact that they're deeply paralyzed because you want complete control of the ventilation as well. So the take-home point for these severe asthmatic patients, the primary thing is oxygenation. That keeps them alive. Avoid gas trapping. That keeps them alive. You let the CO2 climb, and you get you do as best as you can with the bad lung mechanics that you have. So you let the CO2 climb, and that's still okay. They talk about aiming above 7.1 pH, 7.2 pH. But again, you need to ask for assistance. You need to ask for a lot of advice, especially if you're junior. And this is just the worst of a few evils. You avoid barotrauma. So just know that you would use the lowest pressure, like Lloyd said, to achieve some kind of volume for oxygenation. But know as well that when someone has a bronchospastic or severe bronchospasm, a lot of that pressure isn't received by the alveoli. Imagine a very tight bronchiole and an alveolus. The bronchus itself would dissipate a lot of that pressure, so the alveoli doesn't receive that. So don't forget these priorities. Oxygenation, as long as you have oxygenation, the patient has time to heal. Avoid gas trapping with super low respiratory rates. It allows time to exhale. So this is effectively a long IE ratio, but you're guaranteeing the E time is very long. The expiration time is very long. Just know that IE ratio of longer than 1.4 still needs a low rest rate. So it's not the fact of turning your rest rate to 12 and making sure your IE ratios are 1 to 3, 1 to 4. You need to make sure your rest rate is low as well. As the CO2 climbs, you'll be tempted to increase your ventilation, but then this will cause gas trapping in the worst case scenario. If the patient's blood pressure drops, treat all the other causes of blood pressure, obviously, but disconnect the circuit to allow exhalation if you think there's gas trapping. If there's hypercapnia, the body can recover from a super high PaCO2. I've seen unrecordable PaCO2s. This is not ideal, but the patients hopefully will survive. When do you worry about high CO2? So if there's a problem with intracranial pressure, some kind of neuropathology, also cardiac issues because CO2 is a negative inotrope, and maybe if they've got some other complex acid-base abnormalities, you'll need assistance with that. But in these well patients who are otherwise well, high CO2 is the least of your problems, even though it could be a problem down the track. And avoid barotrauma. Even with high pressures, the alveoli doesn't receive all of this pressure. The pressure dissipates along the bronchioles, and that means that you're still likely to be okay with this. I'll just check the chat quickly. How would you approach pre-oxygenation to intubate this patient? To reduce the risk of hypoxemic arrest, would you consider BiPAP and ketamine to try to reduce the work of breathing and pre-oxygenate better? Yeah, I agree. From what I've seen of severe asthmatics, it's very hard to, it'll be very hard to pre-oxygenate them because their oxygen levels are already so low. Also, they're hyperventilating and anxious. I would almost go with whatever you're familiar with. If you've never used BiPAP and ketamine before, don't try it. I would just use whatever I had. I would just assist the ventilation as best as I could. If you're an ED with a Liddell bag, high flow oxygen, and just supporting the ventilations as best as I could. They're often hypovolemic because they have been sick for a long period of time. So I'd have aramine ready, ephedrine ready, and lots of volume running through drip. And then I'd just intubate with lots of good paralysis, use something like a high dose of rocuronium to avoid any histamine release, or even succinylphonium, and just put that tube down and then set it to those priorities that we talked about. Again, if you've done things with BiPAP and ketamine to try and relax the patient or whatever it is, absolutely. But I would probably just do what I do most of the time. So summary, we need to deliver oxygen and remove CO2, avoid oxygen toxicity, volutrauma, barotrauma, and atelectrauma. Programming the ventilator is quite easy. There's only a few modes to choose from and a few settings, so choose those. And then you can choose these settings for basic and tricky cases. So again, the take-home points, volume control ventilation for most cases, what I do, pressure control ventilation if there's leaky circuits, and then SIMV to get patients spont venting or tolerate the ventilator if they're not paralyzed, which is very much ICU. Number 4, if pressure is a problem, use pressure control ventilation. I choose the FiO2 based on safe oxygenation and the situational risk. And then the self-inflating bag solves most ventilator issues. Then we've gone through the asthma priorities, which is a very specific but extremely harrowing situation. Thanks very much, guys. Any questions at all, feel free to ask me, abcs@anaesthesia@gmail.com. I'll get more content out there on this YouTube channel. It's pretty much all I do during lockdown anyway. And I'll put more of this stuff on my website, which is the www.anaesthesiacollective.com. Excellent.
Lahira, that's a really great talk, and I think we couldn't have asked for a better walk and talk through.
Hi guys.
Righto. Thanks again.